All right. So let's go ahead and get started. We are in our June series of these Q&A sessions about all the upcoming changes with Medicaid, and it is a lot. So we're going to get kind of into the weeds today. Please stop, ask questions, put questions in the chat as you have them. Feel free to raise your hand. I want to make sure it is understandable as much as possible to you all amidst all the many things that are going on. So we'll go ahead and thank you to the awesome agencies that have helped sponsor these as we go through. So today we are focusing on kids with developmental disabilities of some sort or developmental delays. So this is usually kids who have qualified for the CES waiver or the CHRP waiver, or who have other developmental needs and have not gotten on a waiver previously or are just starting the process. All right. So we're Family Voices Colorado. I'm Megan Bowser. I'm the executive director at Family Voices, and I'm mama of 4, 2 of whom have disabilities and are on different waivers. All of our staff are across the state and are all parents of somebody with some sort of special healthcare need or disability. So ranging in a wide or covering a wide array of diagnoses and ages and all of the things, but all have lived experience. And we are free to families, so we never charge families for any of the services that we provide. And we do this systems navigation that's really one-on-one help. So if you get to the end of this and you're like, I have a lot of questions still, we are here to help. This is not a one presentation and you're done. We know more information. We are happy to connect one-on-one with you to talk about all of the things more in depth and nuance for your specific situation. And then we do trainings like this, and then we spend a lot of time doing advocacy and policy stuff. So sitting in all these meetings with the Medicaid Agency for Colorado, also known as HCPF, or Healthcare Policy and Financing, and learning these things and helping to advocate for the needs of those with lived experience and making sure our voices are at the forefront of these conversations. And we're also part of the Family Voices National and the Family to Family Health Information Centers. So if you know somebody who lives in another state who could use similar help, there should be a Family Voices or a Family to Family, or maybe both, in their state that could help them similarly to what we do for you guys. So happy to connect you or connect them as well. All right. So, quick housekeeping, then presentation, then question and answer towards the end. I will do my best to stick to these timelines, but if you sat through any of my presentations, you know that is not necessarily my strong suit, but I will do my best because I want to make sure we have time for questions too. A couple things that I ask. One, if you can keep yourself muted if you're not actively asking a question or answering or engaging, that's super helpful. I always love seeing your beautiful faces. But if you keep yourself muted, then we don't hear your dog barking and somebody vacuuming or whatever else is happening on the background noise of all of our screens and lives and all the things. And then today we're kind of focusing on those that are on the CES or the CHRP waiver or have other developmental needs who may have renewals in October, November, December. But if you don't fall in that category, that is okay. We will absolutely answer your questions too. We can answer questions about September renewals today too, absolutely. And most of it will be applicable for anybody. There's a lot of it that is overlap. That's just who we're focusing on. There are some other changes that are like only impact adults, so we're not going to talk about those today. There's some that are really focused on medical side of things, so we're not going to focus as much on that. But things like community first choice, that is the same whether you have medical needs, you're a child, you're an adult, so that is sort of universal. So it's not that they're the content here will be like 90% applicable no matter who you are if you have somebody with a disability, but it will be most applicable if you are under this. So it will be 100% applicable, or maybe 99% if you have a kiddo under age 18 on CES or CHRP. But if you're not in that, please stay. There will be good stuff for you too. And then recording this beginning part, and then we'll give some time towards the end for more individual sort of questions or questions that may be hard to ask without sharing private health information towards the end after we stop the recording. Please, you're welcome to ask questions before that. But if you share things like details about your kiddo's age and name or diagnosis or date of birth or kind of more in depth details, then I can't post this recording due to HIPAA rules. And so please save those towards the end. But you can ask other questions in the meantime. And then always do these kind of disclaimers. I'm presenting what I know to be true right now. So I presented on Monday of last week, and by Monday evening or afternoon, one of the things I'd presented about in the morning had changed already. So things are changing somewhat frequently. So I'm telling you what is true and I know to be true today, and that hopefully won't change this afternoon again. But if it does, then we will do our best to keep you updated as changes happen. And then don't shoot the messenger. I don't work for Colorado Medicaid. And they are not paying me to do this. These are not my programs. Some of them I think are awesome. Some of them I think are not as awesome. But either way, they're not my programs. So I'm just trying to give information. So, all right, let's get going. So, HCPF, or Healthcare Policy and Financing. This is the agency that manages and runs Medicaid, makes all the rules for Medicaid in Colorado, has deemed all of these things priority projects. And these are lots and lots of changes that are all starting July 1st, so in 2 weeks. Thankfully, they don't actually go into effect for everybody on the same day, that there's a gradual implementation. So not it starts generally on July 1st, but not necessarily for everybody on that exact day. And we'll talk about that more coming up. I put in the chat the link to the PowerPoint. There are lots of embedded links in this PowerPoint, so it may be helpful to click on those slides yourself so that you can click on all of the many links as we go through. There's lots of information on Medicaid's website, on HCPF's website about all of these things. So it's always good to have those to look at as well. All right. So there's this whole list of changes. The kind of major one is this community first choice, and most of the others sort of hinge off of this. They're related, they're starting at the same timeline because of how they're connected to community first choice, which is the big overarching change. So, what is this? Right now, depending on how you get Medicaid, depends on what benefits you have access to. So, anybody, no matter how you get to Medicaid, whether that's through income based or Social Security or a waiver or buy in, everybody gets access to the bottom part of this pyramid, the state plan Medicaid. That's what covers your doctor's appointments and your prescriptions and your formula. All those things fall in the bottom, the purple part of this pyramid. Then there's also this long-term care and waivers that are should really be probably more attached than they are in this graphic. And this is if you qualify for what we call home and community based services waivers, or HCBS waivers. So this is if you're on the CES waiver or the SLS waiver or all of these acronym letter waivers. So the Children's Extensive Services or the supported living or the developmental disabilities. So there's 10 different waivers in our state. So that's what's this green part of the pyramid. And depending on which waiver you are on, there are different benefits that are in that green part of the pyramid. So this has things like home modifications and respite and music therapy are all in the green part of this pyramid and depend on which specific waiver somebody is on, what they have access to. So community first choice is taking some of the things, not all, but some of the things that are in the green top part of that pyramid and moving them into or next to the purple part of that pyramid. So it won't matter how you get to Medicaid. Anybody who gets to Medicaid who meets criteria for those services, they're justified as necessary, will be able to access. So there's a bunch of things that are moving, a lot of things that are only available to adults now and are most applicable to adults as well. So things like emergency response systems are also moving. But these are kind of the big three that are moving that most people will be looking into. But it's worth looking at the list to see all of them that's on this link at the bottom. So the kind of biggest ones are personal care, homemaker, and health maintenance. And with those moving, other changes happen when those move. In a lot of ways, it's the changes are on the back end in terms of funding and where funding comes from, more than on the like front end of member how you're actually using it. But there are some changes that impact how you will actually use it as well. One of those big ones is that parents will be allowed to do all three of these services. So, right now, parents of children, so under age 18, can do health maintenance activities only through the Children's Home and Community Based Services Waiver. So, IHSS is what most people call that, but we'll talk more about that in a minute. Um, and sometimes they can do homemaker through some some waivers as well. So through the CES waiver, you could do some homemaker. And parents are not allowed to do personal care at all, ever, for minor children. That's going to expand to where parents can do all three of these services, and all three of them are available no matter how you get to Medicaid. So, any waiver or just Social Security, no matter how you get to it, you could access all three of those. There's also what we call service delivery models or options, and this is how you actually use those services. So there's the service itself, and then there's how that service is received and how it's billed to Medicaid and how people are reimbursed for that, which we talked about a little bit more on our caregiver conversations we just did a couple weeks ago. That the recording might not be up yet, but it should be soon, and we'll talk about it more in August in our caregiver conversations too, but we'll talk about it a little bit today as well. But essentially there's these three services, and then there's three different ways you can choose to get those services. So agency based, IHSS, or what we call CDOS. So in-home support services is IHSS, and consumer directed attendant support services is CDOS. One important thing to know about Community First Choice, or CFC, is it's not a Medicaid home and community based services waiver. So you can have it in addition to a waiver. So you can be on the CES waiver and access Community First Choice at the same time. Or you could be on the SLS waiver and access Community First Choice at the same time. So you don't have to choose a waiver or Community First Choice. You can have both together. And most people will have both together. All right. So why is this happening? More services will be available to more people. That's a good thing. And more ways to access those. So there was some expansion to where people don't have to be CNAs. You could do CNA level care without having to be a CNA, which is helpful. And then the state should get more federal funding for these services than they do for regular waiver services. I always feel like we need to cross our fingers when we talk about funding. All right. So who can participate in Community First Choice? One point to make is it's a choice. There are some services that are moving to Community First Choice. So if you want to access those services, you have to use Community First Choice then. But you don't have to access Community First Choice just because it's a Medicaid benefit. Just like physical therapy is a Medicaid benefit. You don't have to get physical therapy. Not everybody needs it, and even those who need it don't have to do it. So nobody's forcing you into Community First Choice. However, if you currently use personal care, homemaker, or health maintenance activities, you can only keep getting those if you do switch to Community First Choice. That being said, I recommend it for most people. I think Community First Choice will be a really great addition to services. Then the criteria to be eligible for that is you either have to already be on a Medicaid waiver, any waiver, doesn't matter which one, with some weird exceptions with the DD waiver that we will talk about more in 2 weeks. But if you qualify for any waiver, then you meet the eligibility criteria for Community First Choice. Or if you're not on a waiver but have Medicaid some other way, so through low income, through SSI, or through Medicaid buy in, you can still access community first choice as long as you meet what they call institutional level of care, which really means you need help with your activities of daily living. So, help with eating, bathing, dressing, toileting, supervision due to behavior, supervision due to cognitive delays. So, as long as you have some institutional level of care, which sounds scarier than it is, it's really that you need support with your activities of daily living. That could be hands on, or that could be some significant verbal reminders or supervision as well with those tasks. And then to access this, your case manager with the case management agency is going to help manage this program. So if you're on a waiver already, the person who helps manage your waiver will help manage community first choice too. If you're not on a waiver, then you would need to get a case manager with the case management agency. I forgot to mention, I have multiple amazing staff members who are on this meeting too and helping me with the chat. If I try to watch the chat while I talk to you, I get real distracted really fast. So feel free to put questions in the chat. They'll do their best to answer some of them, and then will stop me if there's things I should answer out loud. Or, like I said, you're always welcome to raise your hand and I will answer you live too. Okay. All right. So when does this happen? So if you're currently on a waiver at your what's called CSR, which is your continued stay review, which is when your waiver renews. So every year you have to meet with your case manager and you renew your waiver. And your new service plan starts on the first of a month every year. So, like one of my kiddos, their service plan starts on the 1st of July every year. The other one, it starts on the 1st of December every single year. So, if I am on that, so you will access community first choice when that new service plan usually starts, or you'll have the option to access community first choice then. But you need to start preparing ahead of time. So 60 to 90 days before your waiver renewal, you usually start meeting with your case manager to plan for that renewal. That same timeline should be followed for community first choice as well. So following that at least 60 days, preferably closer to 90 days ahead of time. All right. And then if you're not on a waiver, in theory, you could access starting on July 1st, but it's going to take some time to get all the ducks in a row and all the things processed ahead of time too. So if you started the process today, it's not going to be done by July 1st, but you can start that process now with the case management agency. And then as soon as all the things get processed, you will be able to access community first choice. All right. So what does this process look like? So, first step, if you're on a waiver, is to talk to your case manager. First step, if you're not on a waiver, is to get a case manager to talk to them. They're who has to manage this process. And some case managers are amazing and they're going to be a super great support. A lot of case managers are learning this as well, and it is a lot for them to learn. So, as much as you know going into it, then you and them can partner together better to be able to navigate through all these changes together. So we want you to have as much info as you can. Okay. So there's going to be some assessments that the case manager is going to do or refer you out to be doing, depending on what services you might want to access. So if you're interested in personal care, or if you're interested in um, homemaker services, then your case manager will do this assessment called the Direct Care Services Calculator that will talk about what your kiddos' needs are in that personal care and that homemaker sort of realms. If your child or adult has medical needs, so more medically based needs, they'll also need to do an assessment for those. That assessment won't be done by your case manager starting with uh so July, August, September. So starting with October renewals, That won't be done by your case manager. It will be done by this third party agency called the Skilled Nurse Assessor. But July, August, September renewals that will be done by your case manager. It's an interim process before we get to the final process. Okay, and that will be done. So October and beyond will be done by the Skilled Nurse Assessor. So it's another third party nurse who's going to come in and assess for those more medically based needs. And then when you get all of those assessments done, then the case manager and the family will sit and create the service plan, both for the waiver and for community first choice. Okay, so we talked about kind of three main services: this personal care, homemaker, and health maintenance activities. So let's pause for a minute and talk about what each of those are and how you would know if something falls in each one of those categories. And I'm going to click over to this assessment that your case manager is going to do in order to decide these things. And I have to click too many times to get things to switch. Go. Okay, so when we talk about what needs somebody has, there's two sort of areas of those needs. So there's these homemaker sort of tasks. So this is cleaning, and they've added two other services, this appointment management and money management to this. So your case manager is going to go through each of these sort of items and decide whether the person they're assessing's needs in that area are considered age appropriate. So that means it would be typical parental responsibility. So if I have a 6-month-old, it would be typical parental responsibility for me to be vacuuming their bedroom. No 6-month-old is going to vacuum their own bedroom. So when I have to do that as a parent, that's typical parental responsibility. So the case manager is going to look at these tasks and what their needs are in each of these areas and make this judgment call on whether that is normal, typical parental responsibility, or if that's above and beyond typical parental responsibility and would qualify for hours through homemaker. So they give them this second tab on this sheet that gives them some hints for making those decisions, but they are guidelines. They are not set in stone. The case manager should evaluate each and every situation a little bit differently. So for floor care, for example, it tells you what's included in that, and then says for 0 to 71 months, generally a case manager wouldn't give any hours for that because they're saying for birth to 5-year-olds, most birth to 5-year-olds aren't cleaning their own floors. So that would be typical parental responsibility. But a 15-year-old could usually vacuum or sweep their own room. And so if you need to do that for them, then that would be added in this floor care line here where you could get some time for that. So then the case manager would come back here and say, okay, it takes about 15 minutes. Yes, you agree. How often do you have to clean their floor in their room? Well, twice a week. And then it would calculate out. They're also going to ask this AME question, which means, is this you doing it for them or are you teaching them to do it? So if you're teaching them to do it, then they would mark yes. If you're just doing it for them, then they would mark, or they wouldn't mark anything for this. It doesn't impact the money that's got done. It doesn't impact the hours. It's just for documentation. So they do that for homemaker. And then for personal care, they're going to look at each of these tasks. These tasks get a little trickier because there's 3 areas they're trying to decide between these tasks. So they're saying, what is their need in this area? So what's their need for bathing? Then is that need typical parental responsibility? So if I'm bathing my 6-month-old, that's usually typical parental responsibility, unless they have like a trach or a G-tube stoma or whatever. Bathing a 6-month-old is something all parents have to do for their kiddo. Okay, so is it typical parental responsibility or is it medical? So is it skilled? So that means, does it require, or would it typically require somebody that has some medical training, either CNA level or nursing level to complete? Or is it beyond what's age appropriate, beyond what any parent would need to do for their kiddo, but it's not really medical? Then it would fall in this personal care category. And on this same second tab of the spreadsheet, they go through those criteria as well. So for bathing, it talks about what is it defined to be bathing. And then it has this other section that says what may make this skilled. So the skilled does pay at a higher rate than unskilled. So they're determining where their needs fall. So typical parental responsibility, you don't get any money for that ever. Skilled, you get a higher pay rate for that, or whoever's doing it gets a higher pay rate for that. But if it doesn't meet that skilled, but it's still not normal parental responsibility, then it would fall under personal care. And then they would look at these timelines here to figure out an approximation of how many hours that it would typically take. So then they might go into bathing and say it takes 30 minutes and you have to bathe them 7 days a week because they need it. And then it calculates out the number of hours. All right. So for those three services, there's this combination between what your case manager is deciding and what this third party entity called the Nurse Assessor is going to be deciding about that. So let's talk more about the Nurse Assessor. Okay, so what is this? So currently, if somebody has what we call skilled needs, and anytime you hear me say the word skilled or see the word skilled written on any of these slides or Medicaid stuff, think medical. We know that it takes a lot of skill to help somebody who has some really significant behavioral needs to complete a task, but that's not how they're actually using that word. They're using the word skilled to mean medical. So the nurse assessor, so as things are right now, if you have some skilled needs that somebody is getting paid to do, if you're getting it through long-term home health, so that means a home health care agency is employing a nurse or a CNA to provide that care. The home health care agency does the assessment to decide how many hours are needed for that using some tools that are available. If you choose to get those same needs met through what we call health maintenance activities, so currently for kids, this is available on that one Children's Home and Community Based Waiver, CHCBS waiver through IHSS. So if you get that right now, your case manager is in charge of evaluating how many hours are necessary for that. Your home health agency might help them out, but ultimately it's your case management agent, your case manager's responsibility to determine those hours. So the skilled nurse assessor is going to come in and replace both of those processes with one process that will work for all types of skilled care, so nurse or CNA level care. Okay, so why? Well, there's some inconsistency that's happening right now between home health care agencies, and there's not been a lot of oversight of this since the beginning of COVID. So in the beginning of COVID, they were stopped this prior authorization process. And when they stopped that, then there was not much oversight that Medicaid had over all these long-term home health hours. And so this is their way of trying to get more oversight on that and trying to get some consistency between agencies as things are right now. You may right now have experienced if you go to one home health care agency and get evaluated for CNA hours, they'll say you qualify for 4 hours. And you go to a different home health care agency and they may come back and say you qualify for 8 hours a day. And they're doing the same assessment, but getting vastly different answers. So this is a way of streamlining that where you could take that answer of how many hours and bring it to whatever agency you wanted to go to. Okay, so who needs this? Anyone who needs skilled care. So anyone who currently wants to continue receiving CNA or nursing level care, whether that's through a home health care agency or whether that's through this health maintenance activities through waiver or through community first choice services. Anybody who has that nurse or CNA level need will need to do this skilled nurse assessor at some point. So if you already have those, then you will need it. And if you want to get those, you will need the skilled nurse assessor if you want to start it. Anyone can send the referral to that skilled nurse assessor. We're still waiting for some of the details about how this exactly will look. but anyone should be able to send that referral. So you could self-refer, a parent could refer for their child, the case manager could refer, the home health care agency could refer, any of those people, your doctor, anybody. And then that assessment is done by a nurse employed not by Medicaid, but by a company Medicaid is contracting with. They call it a vendor. And that company they've chosen for this is Telegen. So Telegen right now does some supervision of some waiver services and some evaluations and approvals of waiver services. They're shifting their role and going to do less of that and more of this nurse assessor sort of process where they're going to evaluate, send nurses out either in person or virtually to do these evaluations. So this will be available. This is what changed last Monday, halfway through the day. So this will be available starting August 1st, and it will be required starting August 1st. It was supposed to be July 1st, and they've pushed it back a month to make sure that they get all the things ready that need to be ready for it. So they can send referrals to that starting August 1st, but not sooner. And those referrals will need to go into place a little bit before your renewal and a little bit before you need prior authorization for other services. So you need time to get the assessment done, to get the report, and then to be able to start whatever services. So there's that lead time on that 45 to 60 days or so. From when the referral is sent out to the nurse assessor, they have 7 business days to contact you, schedule the assessment, complete the assessment, and send you their report from that assessment. It is a lofty timeline. I am certainly hopeful that they can meet that, because that would be great if they can meet 7 business days in order to do that assessment. So if you have a July, August, or September renewal, though, so if your CSR is July, August, or September, you're going to wait and not do the skilled nurse assessor until next year. So you won't have to do it this coming year. You'll wait and do it when you get close to your renewal in 2026 instead. All right. So how does this process work? So referral is sent. The nurse reaches out to do the assessment. It has to be what they call face to face. So it has to be over like video call or in person. And then they're going to talk to you about all of their needs. They're going to do this assessment called the Skilled Care Acuity Tool, which is also new, and ask a bunch of questions similar to that direct care services calculator I just showed you. They're going to ask similar questions to that, but about the skilled side of things and then additional things. So, the direct care calculator I showed you doesn't have things like ventilator care, because that's beyond that. So the skilled nurse assessor would talk about any other additional medical needs, giving medications, things like that. You, as the family or the member, can invite other people to come to that meeting, and you can provide them documentation if you have other documentation like medical records or plans of care from your current services that you get, or really any documentation you have that justifies their medical needs might be helpful to bring with you to these. Nobody has done this assessment yet. It is new. So we can give you some tips and tricks, but none of us really know for sure because we haven't done it yet. So we're all sort of guessing to some extent. But it's always better to have more documentation and have more people that know your child well or know their medical needs well to attend things with you, to have that support and that backup. So, but it's up to you. You don't have to bring other people. You don't have to provide them any documentation. They'll fill out the recommendation based on your report, but you can. So then they'll go through all of those needs and talk about so they'll talk about bathing again and say, what do you have to do? And if they determine that it's skilled, then they'll give you points for that skilled need. If they determine it's not skilled, so their need is beyond what's age appropriate, but it doesn't fall in this category of being medically based, then they likely will give you personal care hours. So they'll go to that direct care services calculator I just show you, and they'll fill that out in addition to their skilled assessment. So they'll kind of do both together. Um, and for each sort of task, they'll go through that. And on that direct care calculator, it has that section that says what might make this skilled. That'll be really important to look at because there's some tasks. So one that I often do is teeth brushing, right? Teeth brushing for a 1-year-old is normal parental responsibility. I don't know any 1-year-olds who can brush their teeth themselves effectively. Okay. Teeth brushing for a 10-year-old is not normal parental responsibility. So then it's determining whether their needs falls under personal care or whether it falls under skilled care. And that is this fine line. One of the biggest pieces between those is whether it has a medical component to it. So for teeth brushing, for example, if they're at risk of choking and aspirating, then that will likely make brushing teeth fall under the skilled category. But if they just can't or won't do it themselves, but they're not at risk of choking, they don't have any sores in their mouth or anything like that, then it'll likely fall under personal care. So you get the same number of hours, likely, or however many hours are kind of justified and needed, but the pay rate will be different depending on which category it falls in. So the nurse assessor is going to be doing those determinations for these things. And then they'll talk to you about the different ways you could get those services needs. So let's say you came out with, it showed you need 3 hours a day of skilled care, then they will have a conversation with you about the different service delivery models that we talked about. So do you want to get that skilled care through a home health care agency who's going to employ a CNA or a nurse to provide that care? Or do you want to do it through what we call participant directed programs where somebody doesn't have to have those certifications but can provide that same level of care? So the nurse assessor is supposed to have that conversation. And then they're going to create this recommendation report that they will send off to the family, the case manager, whoever sent the referral to them. And if you can request for them to send it to other people, they'll have like an online portal that you can pull them through, I guess. And then that recommendation report goes to your case manager, and your case manager can help you if you're going to choose participant directed services. They'll help put that into your calculators and get it approved through your community first choice part of your service plan. Or if you choose to go through a home health agency, then that home health agency will take that recommendation letter and use that to submit their prior authorization requests to Medicaid. So asking Medicaid permission to provide those services. One big thing that Medicaid keeps telling us is this report you get is a recommendation. It's not binding. So if that recommendation letter comes to you and you vastly disagree, you think I didn't report this well, or they didn't hear me well, or for whatever reason, this is not enough services for my persons to get their needs met, your case manager can request and put in for more hours than what's on that recommendation, where your home health care agency can request more hours than what's on that recommendation. So it's not binding, it is a recommendation letter. Now, how much they're going to be willing to go above or below what that recommendation letter is to be seen, because none of us have done this yet, but they keep emphasizing that it is just a recommendation. Okay, questions on those before we talk about long-term home health? Yes, Jessica.
All right, so since the health maintenance stuff, the skilled nurse assessor doesn't start till August, do we still have access to personal care and homemaker in July? So we have to wait.
You get to, well, it depends on when your waiver renewal is.
We don't have a waiver, so we're not on the
yes.
waiver, so yeah.
Yep, you could start all of it. So Community First Choice is still launching July 1st. So if you get into Community First Choice in July or August or September, you won't do the nurse assessor until the following year. So you could access personal care, homemaker, and health maintenance right now. You just won't, so you can access Community First Choice, just not the nurse assessor yet.
Yeah. Okay, so we don't get any paid hours then until August.
No, you can get them starting July 1st if you get everything, all the ducks. As soon as your paperwork gets finished to enroll in Community First Choice, you can start getting paid. The nurse
Okay, because we
assessor isn't going to
do,
start evaluating people till August,
right.
but that your case manager can do all the things that they need to do right now. So that skilled nurse assessor being delayed doesn't delay you accessing services, it delays how those are assessed. So the case manager has more responsibility now, starting for October renewals. So in August, they'll start
Mm.
evaluating for people who renew in October. They will get the case manager won't assess them, the skilled nurse assessor will. But everybody before then still gets to access services. It's just a different person doing the assessment, not the nurse assessor.
Okay, because we already have our 100.2 scheduled for this week, so I figure that's kind of good. So, okay. All right.
Yes,
Thanks, Megan.
probably. There's like this weird dance between when things start and when the timeline is. But yes, you should be in a good place. Yep.
All right,
Uh,
thanks.
yep. Jerica.
I apologize. I jumped on about 12:10, but what is the entry point for CFC? I mean, are they still filling out
Case
that
manager.
disability?
Case manager. Your case management agency and the case manager does all the things for CFC, just like they do for waivers, whether you're on a waiver or not. So if you're not on a waiver and you want to access CFC, you need to get a case manager with your case management agency still.
Do they still need to fill out the ARG for CFC?
You do not. No, you do
Oh,
not
okay.
have to have done that. Most
Okay.
people probably will to be able to get to Medicaid, but you don't have to.
Right. Okay. Thanks.
Yep. Yep. You have to have Medicaid. So if you didn't need that to get Medicaid, you don't need it for CFC. All right. Corinne, is there any others from the chat that I should talk about right now? I've
Yeah,
seen
can
lots
you
of things popping
briefly
up. Mhm.
yeah. Can you briefly go over how the skilled nurse assessment recommendations turn into recommendations for private duty nursing?
Yeah. So on the skilled nurse assessor document, so the assessment that they're doing, the skilled care acuity tool, has 3 tabs in it. So it has 1 tab for private duty nursing, 1 tab for CNA, and 1 tab for what they call skilled nurse visits or intermittent nursing. It's like a nurse comes in, does 1 task, and then leaves. So it's not like private duty nursing where a nurse is there for 10 hours. It's like 1 specific task and then they leave. So they'll do those 3 sort of evaluations for any given person and get points, and then the points equals a number of hours. So they'll ask all these questions and then might come out, you qualify, it says 8 hours of private duty nursing, 4 hours of CNA, or 2 skilled nurse visits a day. And then somehow that nurse is going to report those out on this recommendation letter with different options. So if you decided to stick with long-term home health and private duty nursing, you could get these options. If you wanted to switch to health maintenance activities, here's how those hours would add up to really assess the needs and kind of combine them all together. So it should assess private duty nursing instead of the home health care agency assessing for private duty nursing hours. The skilled nurse assessor will do that as well. Did that answer the question?
Yeah, I think so from the chat, but
Yeah.
Jerica continues to have questions about PT and OT and how that will be changing.
They're not, yeah, they're not. I mean, right now, PT and OT through long-term home health, they've not had to have a PAR. We'll talk about that in just a minute too. Um, so they have to have a PAR, which means they have to have permission from Medicaid for PT, OT, and speech, which they haven't had to before. But beyond that, nothing else is changing, especially if you've been getting therapies through outpatient clinics. Nothing is changing at all. If you've been getting them through home health, they just have to get more documentation through Medicaid. But other than that, nothing should really change with those. All right. That seems like a decent segue into this long term home health question, too. So, pediatric long term home health prior authorization. Prior authorization requests are really asking Medicaid for permission to provide services. So some services require prior authorization, some don't. So like if you have a fever and you need to take your kiddo has a fever, you need to take them to the pediatrician to get evaluated. You don't have to have prior authorization for that. You don't have to ask permission, you don't have to get it approved ahead of time. You bring them, they get treated, your insurance or Medicaid pays for those services as well. Some services they want prior authorization for. That means they want you to ask permission before they agree to pay for it. So let's say you've got somebody who needs a new wheelchair. They want to get to approve that before anybody purchases anything or promises anything. So if you wanted to get a new wheelchair, the company would do all these evaluations, collect all this documentation, submit it to Medicaid and say, "Can we please have this?" And Medicaid will either say, "Yes, you got it." They'll say, "No, we don't think any of it's justified." Or they'll say, "We need more paperwork." Or they'll say, "You can have these pieces, but these pieces we don't think are necessary." So they get to make those decisions. So as it is right now, some services require prior authorization, some don't. And there's lists of all of the things that I don't have and don't have memorized either. So long-term home health, pre-COVID, always required prior authorization. They couldn't provide these services other than like a certain number of services. They couldn't provide them long term without getting permission from Medicaid. They paused that during COVID and have tried to restart it once and it didn't go so well. So then they paused it again and now they're restarting it for realsies. So that process is starting now. Okay. So part of why they're doing that is they have to. So our state Medicaid has bosses to federal Medicaid partners. So federally, Medicaid is saying you have to do this for these services. And also, some, not all by any means, but some home health care agencies have been very generous in what they have offered to provide while they've been in this interim where they didn't have to ask permission. And so they want to get a wrap on that and make sure all the services being provided are justified as necessary. All right. So who needs this? So anybody who uses any long-term home health. So this is home health therapies or intermittent nursing or those skilled nursing visits. So where a nurse comes in, maybe gives medications and then leaves. Or CNA visits through long-term home health. Private duty nursing also requires PARs, but those have been back in place for for several years now. It's just these rest of these long-term home health that have not been. So it's on the home healthcare agency to complete this PAR process. So they collect all the documentation and submit it to request this permission. And then they get a yes or a no. So yes, this applies to parent CNA. This applies to non-parent CNA. Applies to anything that qualifies as a CNA or nursing or home health therapies. And then Medicaid outsources this. So they employ this contractor. Right now it's Accentra, who was formerly Keypro. They just rebranded to Accentra, who reviews all that paperwork the home health care agency submits and decides, yes, you can have these. No, you can't have these, or you can have some of them. All right. So when does this need to happen? So agencies need to submit these PARs ahead of when you actually need services to start. But we're in this sort of weird interim period where there haven't been any PARs required. And they're not going to say everybody needs a PAR by July 1st because the system couldn't handle doing all of those at once. So they're doing this gradual rollout of the PAR process too. So therapy PARs, so PT, OT, speech, they're doing what we call a soft launch. So they're submitting them right now. But if they get denied, they're not like officially denied yet. They get more time. But they'll start for real in July for all the therapies. For CNA and intermittent nursing, no matter what kind of Medicaid you have, if you're getting CNA care, whether a parent's providing it or somebody else is providing it, same for intermittent nursing, they will require that skilled nurse assessor and a PAR in this next less than a year. So the home health care agency will need to get a report from the skilled nurse assessor before they can do that. So since the skilled nurse assessor starts August 1 now, so starting August 1, they could submit a referral to that skilled nurse assessor. And as soon as they have that report back, then they can collect all the rest of the documentation and they can submit that PAR, request for approval. And then that PAR will either be approved or denied or partially approved. If they're on a waiver right now, the state is trying to do their best to line up your authorization for your waiver and your authorization for those long-term home health to be lined up together. So if you're on a waiver and you're a CNA for your kiddo, for an example, they want those two timelines to line up as much as possible. Because if your CNA PAR by chance gets denied, they want you to be able to go and access things like personal care and homemaker that might fill some of those gaps. But if your CNA PAR happens before your waiver renewal is due, you're going to have a gap that you won't be able to do CNA and you won't have access to community first choice yet. But as long as your waiver renewal happens first and your PAR for your CNA happens later, then if it's approved, great, you're good to go. And if it's denied, you're on the track where you have access to community first choice, even if you haven't used it yet, and you can switch to those other services. So if you're not on a waiver, your home health agency has to submit a certain number of those PARs every month. So I think it's 15% or something of their PARs they need to submit every month, and they get to choose which ones they're going to submit or not. So for waiver members, they want it to line up. For non-waiver members, it's up to your home health care agency when they want to submit yours. They just have to have them all submitted by May 6th. So everybody's has to be in by May 6th. Okay, so the process looks like you want to start using CNA or intermittent nursing, or you're using those already and you want to continue it. Then you need to go get the nurse assessor done if you haven't had it done already in the past year. So you only have to do the nurse assessor once a year. And then once they have that and the recommendation letter, then the home health care agency collects all the rest of the documentation and gets ready to submit it to Accentra to say, maybe please bill for these services. If they look at that recommendation letter from the nurse assessor and they say, this is not nearly enough, we need more hours than this, then they can justify why those are needed and ask for more hours than are in that recommendation letter. Or they can say exactly what the recommendation letter says, or in theory, I guess they could ask for fewer, but that rarely happens. And they'll submit that. And that'll either be approved, denied, or partially approved or partially denied, however you want to think about it. If it's approved, great, you're good to go. If it's denied or partially denied, then you can either say, okay, fine, we're going to do something else. Or you could choose to appeal that decision where you take it in front of a judge and say to the judge, we need more hours. They said no, this is why we really need them, and let the judge make a decision on whether or not those hours are justified or not. All right. Questions about long-term home health stuff, and then we'll get into a couple changes that are happening to the waiver and some examples, and then more questions. Questions on long-term home health PARs? Either. Yes, go ahead, Jerica, and then Corinne, if you want to find ones in the chat that I should answer to. Go ahead.
I apologize. My brain is just not the same since my accident. But when it comes to so obviously we're in the CES, we've never had access to this. And I am not currently getting paid to do a lot of home therapies, like OT, physical therapy types of things. And we are in October, November renewals. So how would that look? Do I have the opportunity of getting onboarded with a home health agency before, or what does that process look like?
Yeah, so if you think you could qualify, you have the choice when your waiver renewal comes up. You're going to have the choice on whether you want to access those. So that's skilled. So doing therapy homework is usually considered skilled care, at least if it's hands-on. If you're just talking to them, it doesn't count as skilled. Don't ask me why. But if you do hands-on therapy homework for OT and PT and sometimes speech, then that can be counted as skilled hours. So you could choose whether you want to access those through community first choice or whether you want to access those through long-term home health. But if you choose long-term home health, you have to go get your CNA license to be able to be paid to do those. So rather than get your CNA license right now, if you choose to go through community first choice, you don't have to have your CNA license and you can get paid for the same exact things. So you might as well go that route unless you really desperately want to get your CNA license for some reason.
And
So
is
I
there
would
like,
wait until your waiver renewal or 90 days before your waiver renewal, get all the ducks lined up with your case manager. They'll say you qualify for this many hours of skilled care. You can say which model you wanted to use. And if you want to use one that requires a home health agency, so agency based or IHSS, then at that point you can get onboarded with the agency and start billing the moment your new service plan starts for your waiver. That makes
so if
sense?
you, yeah, but so if you choose CFC, that doesn't require the PAR.
Your case manager
Would send it.
does the PAR.
Okay.
So they don't have to ask permission from somebody else. They get to approve it.
Okay. And then the long-term home health, would that be considered the IHSS?
No. So long-term home health is only CNA and intermittent nursing and home therapies.
Okay. So sorry.
So
Thank you.
IHSS is sort of this in the middle. It uses a home health care agency, but it's not long-term home health.
Okay. Thank you.
Sort of a middle ground. Yep. Corinne, do we have ones from the chat or should I go to I'm gonna butcher your name. I'm so sorry.
Why don't you go to Amal and I'm no better, Megan. I don't have it first. And then I have a question that's not necessarily about LTHSS stuff.
Sounds good. Okay. Person whose name I keep butchering, tell me your name so I can try to burn it in my head.
I'm Melinda.
Melinda. See, it's so pretty. Okay, go ahead.
So I already do CNA, and my
Mhm.
daughter is on CES currently with the September 1st renewal. So because she has the September 1st, we don't do the nurse assessor, but you're saying in order to continue my CNA, we have to do the nurse assessor?
Yeah. So it's this tricky thing. So you should start preparing soon for community first choice and your waiver renewal that will start in September. At that point, you can choose to say, you know what, I don't want to keep doing CNA. I'm going to switch to health maintenance activities and switch to IHSS or switch to CDOS. And then your case manager will evaluate, they'll approve hours, and you're good to go until the following year. If in that conversation you say, no, I'm happy doing CNA, I want to keep doing CNA, I'm not going to do these other community first choice things, or I'm only going to do other things, I'm going to keep doing CNA, then they'll do your service plan. That'll start September 1st. If you added personal care or homemaker, you could add those then. Then, sometime in that interim, between September 1st and between May 6th of 2026, your home health care agency would have to submit your PAR for CNA.
Okay.
And so when they go to submit that PAR, you'll have to do the nurse assessor then for them to be able to submit that PAR. And if they submit that PAR and it gets denied, you could go back to your case manager and say, hey, guess what? I changed my mind. I want to add more CFC services. My CNA PAR got denied. I want to add more CFC services. And they can do it at that point because you already are past September 1st.
Okay.
Yep.
Okay.
So
And
for all CNA, you need nurse assessor. For CFC stuff, you only need nurse assessor from October on until next year. It's weird.
okay. And do we know what the pay rate would be for those CFC services?
It varies. So homemaker, so the rates are published online, but they're
Okay, I
hard
can
to
look it up, that's fine.
interpret because home healthcare agencies take a cut of that. So the rates that you see online are what Medicaid pays the agency, and the agency has to pay all their overhead staff and insurance and building and all the things. So you don't get all of that.
Mhm.
Personal care and homemaker usually translate to paying 18 to 20-ish an hour. And then HMA usually is somewhere between like 20 and 24 an hour. It depends on how much overtime you get and such. If you choose to stick in the IHSS route, CDOS is its own whole different thing where you get to choose the pay rates and manage it based on budget rather than hours. And that could be a whole hour and a half and will be a whole hour and a half conversation of its own. But the pay rate for CNA and the pay rate for health maintenance activities are pretty similar. Personal care and homemaker are lower.
Okay, got it. Thank you.
Yep. All right. What do you got, Corinne?
Okay, so this is a pretty specific question, but it's really hard to answer in the chat. So for someone who is getting onto the CES waiver right now, and they've already done their 100.2 last week, what's going to happen with their access to CFC come July 1st.
I so desperately wish I could give you a straight answer to that question. And I have asked and asked and asked and tried to get a straight answer to no avail. I think it depends on your case manager. So chances are, if you did your level of care last week, your service plan is not ready to go yet and probably won't be ready to go until after July 1st. So it depends on whether your case manager pushes through for CFC also or makes you wait until next year. And I don't think there's any clear guidance on whether you'll be able to access it come July when your first service plan starts or if you're going to have to wait until June of next year. I wish I knew and had a straight answer. Everybody I ask at HICPUF and at case management agencies gives a different answer because I don't think there's going to be consistency within it. And I don't like that answer, but it is what it is. Yeah, Jerica.
So when it comes to CDAS, when it comes to like you going over your whole budget, like say if, and then again, CDAS and IHSS is going to be on CFC.
Yes.
Okay. And so is that like you have this like specific budget? Like how do you know what your budget's going to be when it comes to
Yeah.
CFC?
There's calculators that do it, and we'll go through a couple examples here in just a minute, and that hopefully might clarify. But they essentially take all the hours from all these assessments and plug it into a calculator that makes hours that multiply it times the pay, depending on which service, and add all those together, and you get a monthly budget amount, and you have to stay within that monthly budget amount versus you have to use a certain number of hours. So if you qualified for 100 hours in a month and that equaled whatever, $1,000, it would equal more than that. You can use 50 hours, you could use 100 hours, you could use 150 hours, as long as you stay within the dollar amount under CDOS. Versus IHSS, they approve hours, those are the hours you have to use. Versus agency-based, they approve hours, those are the hours you have to use. CDOS, they calculate those hours to equal money, and then you can choose how to negotiate those.
Okay, thank you.
Yep. All right. CES and CHRP waiver changes. So all of these things trickle down to cause changes to another piece. So CFC is sort of the overarching thing, but all these are sort of trickle down effects of that. So one of the services that's available on CES right now is Homemaker. And Homemaker on CES has two different pieces, and those two pieces pay at different rates. So there's basic Homemaker and there's enhanced Homemaker. Okay. So basic Homemaker is moving to CFC. All so just as it is, it's moving to CFC. How hours are evaluated for basic Homemaker, though, is going to be on that direct care services calculator rather than you telling your case manager, I want 10 hours of Homemaker a week, and them saying, okay, that sounds reasonable. You're going to have to go through that calculator and talk about each service and what's needed and what's age appropriate and what's not. But basic Homemaker will all be on CFC. So it will be out of the waiver, which means anybody who accesses CFC, no matter what waiver you're on, could access basic Homemaker. Then enhanced Homemaker on CES has two parts to it. So it has one piece that is teaching skills and one piece that is extraordinary cleaning. So cleaning up like needs for increased sanitation due to like body fluids, things of that sort, or like immune compromise, that extraordinary cleaning piece. The teaching part of enhanced Homemaker is going to CFC also, being mushed with basic Homemaker, and will be paid at the basic Homemaker rate. So if you're doing that teaching portion of enhanced Homemaker, those hours have to move and the rate will go down for those. If you're doing extraordinary cleaning part of enhanced Homemaker, so you're doing that sanitation thing because your person's immune compromised or they vomit all over, whatever it is that you need some sanitation piece, that is changing. It's going to be more closely scrutinized to this very specific sanitation sort of lines. And the limit on it is it's going to have a tighter limit on it. So right now it's 10 hours if a parent is providing it, but it's has no other specific limits on it within the CES waiver. That service in and of itself will be capped. That'll come out to about $6,000 per year. One of the good things, though, is right now you can only bill that extraordinary cleaning part of enhanced homemaker as a per hour, right? You can bill her per 15 minutes. They're going to expand it to where it can be for projects too. So in theory, it could pay for like carpet cleaning, a carpet cleaning company to come out and clean your carpet, because they don't charge you per hour. They charge you per job, a dollar amount. So the extraordinary cleaning can be used on dollar based or per hour, but it's limited to $6,000 a year, which comes out to about 3.5 hours a week, if that's what you're going to use. And then there's still this 10 hours per week limit if it's done by a parent of a child. Will not apply to parents of adults, but only parents of children for the CFC homemaker services. And then there's no extra limit on parents for the extraordinary cleaning piece. But like I said, it's caps out at about 3.5 hours a week. All right, the other CSC CHRP waiver changes is Community Connector. So Community Connector is currently available on both of those waivers. Right now, there's a limit on the CES waiver that you can only get 10 hours a week, an average over the year. So you can use more one week if you use less another week, but an average of 10 hours a week of Community Connector if it's provided by a parent on the CES waiver. That is changing with all of these changes. It just got approved Friday of last week. So hot off the presses, to where it's 10 hours no matter who provides those Community Connector hours. So some people right now, a parent provides 10 hours and they might have somebody else who comes in and provides another 5 hours per week. That will have to change unless you get special permission for why you need to exceed those 10 hours. So it's 10 hours no matter who provides it on the CES waiver. And the CHRP waiver has always been that way, that it's 10 hours. Okay. Yeah, you can utilize respite. It's just Community Connector that is limited to those 10 hours. And there's still an exceptions process. But yeah, everybody that goes over 10 hours a week has to do that exceptions. Then the other change is the 16 hours per day cap. So adult waivers currently have some limits on like 40 hours a week for some things. There's limits there. That's all going away. The only two limits that are going to be out that apply specifically to parents is this 16 hours per day applies to anybody. So whether you're a parent, whether you're not a parent, whether you're a nurse, whether you work with 5 Medicaid clients or whether you work with 1 Medicaid client, you can work 16 hours per calendar day and no more that Medicaid will pay for. It's more related to like labor laws than it is to Medicaid specific, but they've never enforced this previously and they're going to start with all these changes. So the same timeline that you can access Community First Choice, you're going to be held to these changes as well. So if you currently do 17 hours a day for your kiddo under IHSS, you're only going to be allowed to do 16 hours a day for them ongoing. Somebody else is going to have to come in and do that additional hour. So your kiddo might qualify for 24 hours a day of care, but that has to be provided by at least 2 people because one person can't do all more than 16 hours per day. Also means if you've got multiple kids in your household and you do 10 hours a day for one kid and 10 hours a day for another kid, you're not going to be able to do that anymore. You as an individual care provider can only be paid for 16 hours in a day. So you're going to need to figure out how to make those logistics work. One option is to switch to CDOS, where you're more budget based and you can reduce the number of hours but get paid more per hour. Or an option is to find other people to come in and to support you, which is always great when we're able to, but I fully recognize is often hard to get. All right, should I go to example cases? Burning questions before I do a couple examples?
I think examples are going to be very helpful.
Cool. All right. Example, Henry. So let's pick Henry. Henry is 8 He has level 1 autism, some other diagnoses and such, and is on Medicaid buy-in for children with disabilities. So Henry has never qualified for a waiver because he didn't quite meet the qualifications for CES or for CHRP or for either of the more medically based waivers. So he's not used them. He uses some Medicaid services, though, therapy, ABA, those sort of things. Right. So anytime, starting now, Henry can start this process. So he would do a referral with his case management agency, or rather his parents. He's only 8. Would do a referral with the case management agency and ask to get assigned a case manager. So that case manager would do their level of care screening. So they would do that 100.2 assessment where they ask about all the activities of daily living. And assuming he meets what they call institutional level of care, so he really needs help with some of those activities of daily living, then he would qualify for community first choice. So if he qualifies, then the case manager would do this direct care services calculator. So that Excel sheet that has the homemaker and the personal care. And then they talk to the family and say, none of his needs really fall in that medical category. So we're not going to do the nurse assessor. We're not going to send a referral. We're just going to stick with the direct care services calculator. And once all those things are done and the case managers approve the care plan, then he could start services as soon as July 1st or whenever all the paperwork got finished. So let's say they do the direct care services calculator and it comes out to an hour and a half a day of personal care and an hour and a half per day of homemaker. This is just, I made these up. Okay. So some options on how Henry could manage, or Henry's family could manage his care. So the 3 service delivery options are agency-based, IHSS, or CDOS. So agency-based, then somebody would need to be employed through a home health agency as a personal care provider. That could not be Henry's parents under agency-based. It would have to be somebody else. So a babysitter does that, provides 45 minutes of personal care, 30 minutes of homemaker every day. And then grandpa comes in and provides 3.5 hours of homemaker a week through the same agency. And then they keep doing the therapies and stuff they were doing. That is an option. If they switch to, oh yeah, and I forgot, does Henry live with his grandparents? Yeah, he lives with his grandparents. They're his legal guardians. So they count as parents in this situation. They're legally responsible persons. All right, if they instead decided to switch and do IHSS, so that service delivery model in their conversations with their case manager, then grandpa could provide an hour a day of homemaker, 1.5 hours a day of personal care. He'd probably get paid somewhere around $18 an hour, maybe 19 or 20, somewhere in there. And then on weekends, they could have somebody else come in and provide some of those hours as well. And then it could continue all the Medicaid services the same too. The other option is this CDOS world. So CDOS, they would take those same hour and a half a day of personal care, hour and a half a day of homemaker, put them in this, what they call a monthly allocation budget, and calculate it out what the budget would be for a month instead. So essentially, it's almost what an agency would get paid under IHSS, that equals that budget. It's slightly less, but it's not a whole lot less. But under CDOS, there is no home health care agency. So Henry, or Henry's authorized representatives, so whoever's managing his care, in this case would be grandma, is the authorized representative. She counts as the employer for anybody who provides these services. And grandma's overhead expenses are going to be way less than a home health care agency's overhead expenses because grandma's not allowed to be paid to be the authorized representative. So his budget comes out to around $1,900 a month. And so Henry's grandpa can provide some care on the weekdays, care on the weekends, and they get to choose what that hourly rate is going to be, as long as all of that care provided does not equal over that monthly budget at the end of the month. You get a little bit of leeway, but it's not much. So you need to make sure you're staying within that budget. But you could choose to have double the hours at half the pay, but you have to pay minimum wage. Or you could choose to have half as many hours, but double the pay. And so you can provide more. You also end up with a lot more money because most agencies take 30+% cut of what Medicaid pays to pay for all their overhead expenses. So when you get to cut that out, there's a lot fewer overhead expenses. And you can have multiple people provide that care. So it can be grandpa, it can be the babysitter, it can be all sorts of people coming in and providing that care. It does not have to be family members. But you do have to have somebody who is the authorized representative who is not also providing care. So grandpa can't provide care and be the person who manages everything and counts as the employer. So that person has to be a totally separate adult than the other people, than the people providing care. All right. Example of Liam. So Liam at 6 has cerebral palsy, epilepsy. He's complicated. He has a trach. He uses a ventilator at night, has long G-tube feeds, J-tube feeds, and he's on the CES waiver, which renews in November. So right now he's getting CNA, private duty nursing, homemaker, other things that are provided specifically through the waiver. All right. So let's say Liam in August or September has their renewal meeting with the case manager. They do the normal waiver process the way they always have. And they're going to have to relook at the homemaker hours that he gets. So instead of having those basic homemaker and the enhanced homemaker, they're going to have to relook at that versus what will go to CFC and what falls in that extraordinary cleaning bucket. Then they'll talk about community first choice. Because Liam has a lot of skilled needs, they're going to send that a referral to the skilled nurse assessor for them to evaluate. Then within 7 business days of that referral done, they should have the assessment completed and the report in hand. And then the family and the case manager need to decide what they're going to do now. So between that and the direct care services calculator, and they need to finalize the service plan and choose which service delivery model they're going to use. If they decide to stick with an agency and do long-term home health, then they'll need a PAR to be submitted for that sometime in that next year. And they'll probably be on the early end of that since they already had their nurse assessor. And then in November, all of those things would start together. So let's say they do this assessment and it came out to 20 and a half hours if they chose health maintenance activities, or they could break those down and he could do 8.5 hours of CNA, 12 hours of private duty nursing. And then they did their direct care services calculator. It came up with 0 hours of personal care because all of his care needs really fall in that medical model. So he doesn't have any that fall in personal care. And then he qualified for 30 minutes per day of homemaker services. Okay, so if they wanted as little to change as possible, then they could keep doing CNA the way they are, keep private duty nursing, though he was only staffed 2 days a week, so that kind of stinks. Keep doing all the other therapy stuff that they had through the waiver. The only thing that would have to necessarily change is homemaker. So the basic homemaker, they reduce the number of hours. So is that 3.5 hours per week, and it would be through homemaker through community first choice. And then they could keep that extraordinary cleaning, but it would be limited to 3.5 hours a week of extraordinary cleaning based on that new $6,000 a year cap. If they chose instead IHSS, they could do this mushing of private duty nursing some nights and IHSS on some nights. So they could mush those two together to make sure they're getting all the care needs they have provided for. But then on those nights when they don't have a nurse, they could do those health maintenance hours through community first choice in that instead. The extraordinary cleaning would have to change the same way. The other therapies could stay the same as they did with the minimal changes one. Okay. The other option is if they switch to CDOS, then they, instead of being told he would qualify for 20.5 hours of health maintenance, this many hours of personal care, 0 hours of personal care, 30 minutes a day or 3.5 hours a week of homemaker, and they would push all those together into this monthly allocation worksheet and come up with a dollar amount instead. So for Liam, it might come out to about $21,000 per month. So then they have that $21,000 and they can choose how they want to allocate that money to pay people for a certain number of hours. But they don't have to use the 20 hours, the 3.5 hours. They can use more of some service, less of another, as long as they stay within that budget. So under this, he qualified for 20.5 hours a day of health maintenance activities, but mom can't do all of those because she's limited to 16 hours a day. Under CDOS, she can instead take that 20 hours worth of pay and mush it into 16 hours worth of work and just get paid a higher rate. So she gets the same amount of money, but only bills for 16 hours per day. Because of CDOS, you can adjust the hours and the budget as long as you stay within your budget. But stepdad is now the authorized representative, so he's not allowed to provide that care through any of those CFC services or CDOS services. Then they still have to reduce their extraordinary cleaning and can keep their other therapies as they had before. Okay, I'm going to skip the third example and go to this too. So happy to stop. I'll stop the recording here in just a minute. Answer any questions. Here's our main contact phone number and our main email. I recommend reaching out by phone or by email if you have questions and you want to talk with somebody individually to go through your specific situations. You're welcome to email me as well. I put my email address on there, but the odds of your email getting lost and buried in my inbox are decently high. I don't like to admit that, but it is. So you're better off getting assigned to somebody if you reach out to the main ones, but you're welcome to email me if you would prefer to. I also put on here the link to our community first choice page on our website that we've added that has links to our YouTube channel and the recordings we have on there, and like a toolkit and some other resources that we have on there as well. All right, any general questions before I stop recording?
Can you talk about what is included in the budget in CDAS? Like waiver programs don't get included and things like that.
Yeah, the only things in your CDOS budget is personal care, homemaker, and health maintenance activities. So that's skilled care and those unskilled care needs. That your CDOS budget is completely separate from any waiver budget that you have, which is a change for some of the adult waivers. Right now, CDOS is available for adults on the SLS waiver, but it's part of their waiver budget. It won't be anymore. And it's not part of your CES budget. It has no other budget constraints on it. It's just those three services. So you get that, like for the Liam example, that 21,000 is just for those three services combined. Then he can have PT and OT and hippotherapy and massage therapy and all of those other services that he might qualify for from regular Medicaid or from waiver benefits are completely separate from that CDOS budget. They're not part of CDOS.
And just to really hammer this home, the annual waiver budget that CES has, how does that coordinate with CDOS budget?
Totally separate. So, which is nice if you have homemaker services, for example, right now that are using part of your CES annual budget, those are getting pulled out. So now you've got more money in your CES budget and you have this separate CDOS budget, or if you used a different model. But your CES budget and your CDOS budget are completely separate things. And the CES budget isn't decreasing or anything. It's staying the same amount that it has been for now. All right. I will stop this.